Targeted therapies in melanoma have their extremely important role. At this point we know that targeting the mutations in melanoma, starting with the BRAF, really brought a revolution in how we manage this very deadly and serious disease. The revolution started really in 2009 with development of first BRAF inhibitor, vemurafenib, but very soon afterwards we developed dabrafenib, and then the combination with MEK inhibitor, which we know actually abrogates the feedback activation of the MEK kinase pathway. What is really important, and we didn't know about it until we actually got into these clinical trials, is that when you activate the BRAF mutated gene in melanoma, you actually become very dependent as the cell on it. However, if you only block it with one single inhibitor of BRAF gene or the mutated protein, then actually you will still have activation of the MEK kinase pathway through the reverse activation of the MEK and RAS. However, if you are using the MEK inhibitor with it, you will have deeper inhibition, you will get better responses and more durable. Of course, only 10 to 30% of patients will become long-term responders, and we do know that it actually is correlated with the low tumor burden, low LDH, and also with the ability of the patients to activate their immune system. So there is a big interplay between targeted agents and immunotherapy. So in my opinion, actually, the next wave of trials is focused on combinations of targeted agents with immunotherapies. And we are still trying to find the optimal dose and schedule. In our trial at Vanderbilt University, we actually combined dabrafenib and trametinib with ipilimumab, a CTLA-4 antibody. And we have found that while dabrafenib ipilimumab was well tolerated and fairly efficacious, although we cannot claim it was more efficacious than giving the drug sequentially, when you use the triplet, i.e. dabrafenib, trametinib, and ipilimumab, we have seen more the toxicity, especially colitis, as well as perforation in 2 out of 7 patients. So these will be very important trials, and here in Naples this year, Dr. Ryan Sullivan from Mass General was presenting data on combination of vemurafenib and the atezolizumab, the anti-PD-L1 inhibitor, and the data looked very promising. At the same time, we have combinations going on with targeted agents to BRAF or BRAF-MEK, high-dose IL-2, anti-PD-1, and et cetera, et cetera. The other interesting question is what to do with patients who progressed on both BRAF and MEK targeted therapy, the ones who have the BRAF mutation. And we are not sure yet. However, a combination of using the MDM2 inhibitor seem to be actually of not just theoretical but practical interest, and we are conducting several trials including MDM2 inhibitor AMG 232 in that setting. Lastly, we know about c-KIT mutation in melanoma, and 3% of patients will have it, and their use in c-KIT inhibitors seem to be associated with responses as well as durability. We still do not have good targeted agents for RAS mutated or NRAS mutated melanoma, although some promise is being carried by combination of MEK inhibitor. Dr. Ascierto had a very nice presentation at ASCO 2 years ago on MEK 162 inhibitor for those patients, and with the inhibition of cyclin-dependent kinase 4/6 inhibitor, it seemed to be more potent, but also more toxic, and these were challenges in combinations targeted therapies. And last but not least, some of the immunotherapies may actually be exquisitely suited to target patients with NRAS mutation, perhaps because they carry a high mutation load, which is associated with better response to immunotherapies. And work from our group as others show that using ipilimumab high-dose IL-2 or PD-1 inhibitor was associated with better numerically responses in the patients with NRAS mutation than if they were either BRAF mutated or for wild type for both genes. So the targeted therapies are here to stay. They do help activate immune system, and we do know that if you are progressing on targeted therapies, that you also have probably some epigenetic changes associated with the poor immune response. Therefore, the challenge will be to learn when we should use the targeted therapy, for how long, and when to switch or combine with immunotherapy. And we are going to do wave of trials aiming that way, including some clever imaging, including our own immuno-PET imaging, which we are trying to develop at Vanderbilt, as well as other centers such as UCLA and the Harvard groups as well.